Your knee pain isn't coming from your knee. I know that sounds impossible, but I'm about to show you scientific evidence that will change everything you think you know about joint pain. I'm Lou Nicolettis and I apply functional medicine principles with the latest pain science and physio to find root causes and ensure my clients get the very best outcomes. This case was from a couple of years ago and fundamentally changed how I treat every osteoarthritis patient I see. When I found the real source of her pain, she went from needing surgery to hiking mountains. By the end of this video, you'll understand exactly where joint pain comes from and why treating the joint itself often fails completely. Since studying pain science and functional medicine, I now treat the systems responsible for the joint pain, and my success rate is so much better. What I'm about to explain is based on the very latest pain science research that most practitioners either don't know or they don't apply. But it does explain everything. Cartilage, the stuff that's worn away in osteoarthritis, has absolutely no pain receptors, or the proper term, nociceptors. Zero. It's anatomically impossible for cartilage itself to generate pain symptoms. This is basic anatomy that somehow gets forgotten in clinical practice. So research actually indicates that the arthritic pain often originates from inflammation in the subchondral bone, which is the highly innervated bone tissue directly underneath the cartilage, and also sometimes inflammation in the synovium of the joint. These inflammatory chemicals activate nociceptors, creating nerve signals that have nothing to do with the amount of cartilage damage or wear and tear visible on imaging. And this really explains why studies consistently show poor correlation between X-ray severity and actual pain levels. The X-ray shows structural damage, but pain actually comes from active inflammation, which can come and go. But here's where it gets really interesting. That bone inflammation isn't random. It's often driven by systemic inflammatory processes that are going on throughout your entire body. Let me show you exactly what I mean with a patient I treated a couple of years ago who really changed my thinking on joint pain. Sarah was 51 with severe pain in one of her knees that made walking her dog agony. She came to me for physio, and yes, physio can be amazing for joint pain. But when I spoke to Sarah, she actually had a lot of other symptoms going on as well. She described constant exhaustion despite sleeping 8 hours a night. She was bloating after every meal. She had lots of brain fog, so bad she couldn't focus at work. Her GP had run basic blood tests, cholesterol, blood sugar, a single thyroid marker, B12, everything came back as normal. Even more depressing was that her X-ray showed bone-on-bone arthritis in her knee. Sarah had seen an advert for my functional medicine program and asked if I thought that would be useful. But if I'm completely honest, what I wasn't thinking about specifically at that point was her knee. In functional medicine, we look for dysfunctions or dysfunction in the body rather than looking at individual organs or symptoms. When we're looking at blood work, we use much tighter ranges because we're looking at what's actually optimal for health. Standard ranges that most doctors use are based on population averages from an aging and sick population, and they're really there to identify severe illness or disease rather than looking for what's actually healthy. When we look a bit deeper, and we also use optimal ranges, and also when we look at correlations and patterns between markers, we can reveal so much more about the state of somebody's health. When I looked at Sarah's bloods, and we did a full comprehensive panel of about 65 markers, her blood revealed 10 different dysfunctional patterns. When we used optimal ranges, her CRP, which is one of the inflammation markers, wasn't just high, it was 5 times optimal. She had severe folate deficiency, 79% below optimal, vitamin D deficiency versus optimal, vitamin B12 deficiency. Research indicates that these nutrients are actually crucial for inflammatory regulation and for tissue repair. So her body couldn't heal because it didn't have the raw materials. Her immune panel strongly suggested SIBO in her gut, or small intestine bacterial overgrowth. People with SIBO often experience brain fog, fatigue, and lots of aches and pains. And her thyroid was underperforming, so her TSH was double the upper limit of that optimal range. Literature suggests that thyroid dysfunction can amplify inflammatory processes throughout the body. I created a comprehensive protocol for Sarah, targeting all 10 dysfunctional patterns. Anti-inflammatory nutrition protocols, some gut support to address the SIBO, targeted supplementation for her deficiencies, hormone support, and thyroid optimization. After just a few weeks, Sarah's brain fog, cleared and she had much more energy. At 5 weeks, she told me that her knee was actually feeling much better. And a couple of months down the line, she completed an 8-mile hike pain-free. I hadn't specifically been thinking about Sarah's knee when I wrote her program, but it turns out when all of her other symptoms improved, her knee pain also improved. Research suggests that systemic inflammatory markers like CRP can often predict joint pain severity better than X-ray findings. Sarah's blood work explained everything her scans couldn't. In Sarah's case, inflammation was likely being driven by multiple factors, severe nutrient deficiencies, hormones, gut imbalances. Her knee was just where she felt the systemic problem more acutely. And this isn't magic, this is applied pain science. When you reduce systemic inflammation, you reduce the inflammation in that subchondral bone and the pain can settle. And this is why joint injections can provide temporary relief, because they reduce that local inflammation. But if you haven't addressed the systemic sources, the inflammation is going to return, and so does the pain. When we retested Sarah's blood work at 4 months, her CRP, the inflammation marker, had dropped from 7.5 to 2. Her nutrient levels had normalized, her thyroid function had massively improved, and her immune panel had cleared, suggesting that the SIBO had settled. This case demonstrated firsthand that joint pain can often be a symptom of systemic dysfunction. Same X-ray, same structural damage, but completely different inflammatory environment and therefore completely different symptoms. When I last saw Sarah, she was continuing to stay active. We completed a course of physio to get back all the strength that she'd lost while she'd been in pain. She joined a gym. She's lost weight, which was something she was really finding impossible to do before. Probably a combination of the sluggish thyroid, the SIBO, and the fact that her pain was stopping her from exercising. And she's been going on lots more walking holidays, and the brain fog and fatigue and bloating had completely gone. Her knee is now an occasional mild niggle instead of daily severe pain. So your joint pain might be your body's alarm system telling you that something is systemically wrong. Ongoing research is showing that there's much more to arthritic pain than wear and tear. So if you've got joint pain and standard approaches haven't provided lasting relief, ask yourself, has anyone ever looked for systemic patterns that might be contributing to your symptoms? If you want to know more about functional medicine, physio, and the very best blood markers to order if you're struggling with aches and pains, there's a link in the description below to join my mailing list and grab some free guides. And if this gives you a completely new perspective on joint pain, hit that like button and tell me in the comments, have you ever noticed that your pain levels vary a lot, day to day, month to month, even though your scan hasn't changed?